Good evening, dear students. Welcome to you from Sri Rama Hospital, Jakaipet. Yesterday we have discussed about the etiology and clinical manifestations of atherosclerosis and peripheral vascular occlusion due to atherosclerosis. Now let us study about the remaining part of the atherosclerosis and other chronic occlusive arterial diseases. Investigations are a case of peripheral occlusive arterial disease due to atherosclerosis. Same investigations as described for chronic occlusive arterial disease. Already we have discussed at length about investigations for chronic occlusive arterial diseases. So these investigations will hold good for any other occlusive arterial disease. That means if you are asked in the examination to write about Burgess disease, that is a chronic arterial occlusion. So same investigations you can write there. Atherosclerosis, you can write the same investigations. So I am not again repeating them here. Can you please tell me the investigations in just briefly, just headings? The investigations for a case of chronic occlusive arterial disease. Good, these are the regional investigations. What about general investigations? General investigations. General investigations are mainly for the hemoglobin percentage, RBC count, then blood for glucose, lipids. That means you would investigate for the atherosclerosis. Then, if peripheral arterial disease is present, means usually the patient will be having associated coronary heart disease. That is why you must also go for cardiac investigation, ECG and TMT or treadmill test. Yes, good. So the non-invasive being Doppler's probe, duplex angiography, CT or MRI angiography. The invasive being direct and indirect angiography and DSA. You go for angiography only when there is a need for surgical intervention. Management, general management, same as for chronic occlusive arterial disease. What is the general management for chronic occlusive arterial disease? Yes, good. Yes, stop smoking. Yes, very good. You also should give platelet modifying drugs like clopidogrel and aspirin. You must reassure the patient workload on the calf muscle can be reduced by high heel shoes. Protect the gangrenous or ischemic areas. Specific management. The occluded vessel is identified by duplex scanning and later by arteriography. So first of all, you have to identify the occluded vessel. which part of the vessel is occluded and what is the extent of the occlusion. Then you can go for arteriography. Arteriography will give clear demarcation about the site and extent of the occlusion. There is no medical management for relieving atherosclerotic occlusion. It is managed by interventional therapy or by open surgery. The type of treatment depends upon the site, the extent, presence of distal obstruction, and general condition of the patient. So if atherosclerotic obstruction is there, you give general measures. With that, if the ischemic changes can be controlled, it is okay. Otherwise, you have to go for interventional therapy, because there is no medicine which can lyse the atheromatous plaque. Or you can go for open surgery. What is interventional therapy? Percutaneous transluminal angioplasty. This is percutaneous transluminal angioplasty. Angioplasty is a procedure to open narrowed or blocked blood vessels. An arterial stent is a small tube that is often placed during or immediately after angioplasty to keep the open narrow segment open. So keep it patent. Indications for interventional procedures: intermittent claudication, rest pain, and in gangrene cases, also you can do this interventional procedure to reduce the level of amputation. So in gangrene case also you can do it to reduce the level of amputation. For example, if the patient comes to you with atherosclerotic obstruction of femoral artery, the patient may present to you with a gangrene of the great toe. So where you have to do the amputation? Tell me. A patient with atherosclerosis comes to you. He comes to you for gangrene of the great toe, but the obstruction is at the femoral artery. Now, where do you do the amputation? Where do you perform the amputation? He is having only great toe gangrene. You amputate great toe, is it not? Am I right? Is it okay to do amputation of great toe? Is it okay or not? Why? Why we have to go for a level up? And up to what level you go? So you have to go to a level where the normal perfusion is present. For example, a patient who is having femoral artery obstruction, if it is there in the proximal part of the femoral artery, then to the profunda femoris collateral supply, the limb, up to the whole thigh will be perfused normally. So you have to go for amputation at the below knee level. If it is in the mid part of the thigh, obstruction is there, then you have to do amputation at the above knee amputation. That means you have to do the amputation at a place where there is good and normal arterial perfusion of the tissues, as evidenced by the investigations. That means you do the duplex scanning and evaluate up to what level the blood flow is there, then up to that level you have to do the amputation. So patient came to you with grade 2 gangrene and you are doing above knee amputation or mid-thigh amputation. So then patient will say, sir, I am having only this part of limb gangrene. You are removing my whole limb. That is why in those cases, what you do is you do interventional procedure to relieve the obstruction of the femoral artery. Once the femoral artery obstruction is relieved, the perfusion will be there up to the ankle or up to the foot. Once the restoration is done, then you can limit the amputation only up to the grade 2. So the part which is gangrenous, that can be removed. This is called the salvage operation, limb salvage operations. So even if the patient is having gangrene, you can do the interventional procedure. Percutaneous transluminal angioplasty is useful in iliac and femoropopliteal segments. How you do the procedure? A balloon is passed into the stenosed area by Sellinger's technique after arteriogram, and the balloon is inflated to dilate the stenosed area. Stents are placed in the dilated stenosed segment to keep them patent. So this is a stent. So you can keep the stent in the place where it is being dilated. Next, I will show a small video clip about angiography and angioplasty.
Angioplasty is designed to restore the flow of blood through coronary arteries narrowed or clogged by atherosclerotic plaques or blood clots. When you arrive at the hospital, an angioplasty procedures groin area and inserts a needle into your femoral artery. Once the needle is placed, a guide wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath, permitting access to your femoral arteries. At this point, you will be given a blood thinner to reduce the risk of blood clots. Next, a soft, flexible catheter is slipped over the wire and threaded up to the heart. The procedure is monitored using a continuous X-ray imaging device called a fluoroscope. You may feel pressure as the wire and sheath are inserted through the groin and pushed through the artery, but you will not feel their movement inside your arteries. At this point, your doctor will remove the guide wire, position the tip of the catheter just inside the coronary artery to be treated, and inject a special dye. The dye allows the fluoroscope to take X-ray images, called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with the dye. You may feel flushed or slightly nauseated when the dye is injected. Once the blockage is identified, your doctor will insert a flexible guide wire into the artery and advance a balloon-tipped catheter over this wire and into position at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing blood flow through the artery. You may feel some chest pain while this is happening. The same procedure is repeated for each blockage being treated. Afterwards, your doctor will withdraw the deflated balloon and catheter from your arteries. Some patients will receive a coronary stent, which is a small tube made of wire mesh designed to prop open the artery once it has been treated. A collapsed stent is placed over the deflated balloon as it's moved into position. When the balloon is inflated, the stent expands and locks into place. After the balloon and catheter are withdrawn, the stent remains behind to hold the artery open permanently. After your procedure, a pressure bandage will be applied over the femoral artery to prevent.
Okay, this is the procedure of angioplasty and angiography. Sorry, stent placement. Surgical management of atherosclerotic plaques. Indications: severe symptoms where angioplasty has failed are not possible. So the first line of treatment is angioplasty. Of course, in the video I have shown you the coronary angioplasty and coronary stenting, but the same procedure can be adapted to peripheral arteries also. The surgical procedures being atherectomy or thromboendarterectomy. Here, when there is short segment, eccentric plaques, they are removed and the arterial defect is closed with a vein patch graft. So only one small segment of atherosclerotic plaque is there causing obstruction. So you just remove that plaque and close the artery with a vein patch graft. Already I have shown you the vein patch graft. This procedure is not done nowadays. The procedure that is done is the arterial bypass. So the occluded vessel are bypassed by the anastomosis of proximal vessels to the distal vessel with the help of a graft. For example, you can see here the femoral artery is thrombosed due to atherosclerotic plaque. Now you place a graft proximally and connect it to the distal segment where there is good flow. So now the blood will flow through the bypass and perfuse the limb. So this is called the arterial bypass operation. So the grafts used are prosthetic grafts made of Dacron for larger vessels like aortoiliac and aortic iliac vessels like that. Autologous reverse saphenous vein graft for medium-sized vessels, example femoral artery. So for the femoral artery, you can use the reverse saphenous vein. That means you take a segment of long saphenous vein, you ligate its tributaries, then you reverse it. That means the distal one is made proximal, the proximal end is made distal because it has valves. So if you place it as such there, the valves will cause occlusion to the blood flow. So you have to reverse it so that the valves will not cause destruction. Or else you can destroy the valves and then you can do the grafting. Or else you can also do arterial grafting. If possible, you can take nearby artery and do the bypass operation. How? For example, you take the coronary artery blockage. Here, the left descending artery is having the atheromatous plaque here. Now what you can do is, on the front of the inner side of the chest wall, there is internal thoracic artery, which divides into musculophrenic and superior epigastric artery. So you cut it just before its bifurcation. So this is the internal mammary artery, and get it and anastomose it to the left descending artery below the obstruction. So now the blood from this artery will cause perfusion of this part of the system. So this is called arterial grafting. So the procedure is bypass grafting. You do it with the veins, prosthetic material, or with arteries. So this is the operation of choice in atherosclerosis. You can see here this is a vein graft. For example, there is a plaque in the right coronary artery. So a graft is placed between the aorta and the right coronary artery distal to the plaque. Amputation, if the patient comes to you with the stage of gangrene. Amputation is done at a level where good vascular perfusion is present. The perfusion by proximal vessels can be improved by arterial surgery and thus confine the amputation to the gangrenous area only. This is called salvage arterial surgery or salvage limb arterial surgery. Already I have explained to you the about this salvaging surgery. That is about atherosclerosis. So we will go through all the occlusive arterial diseases separately. First, we discussed about the in general about occlusive arterial diseases. Then we studied about the atherosclerosis. Now we'll go to the other arterial diseases because these diseases are given now and then as short notes question, and some of them are given as even essay questions. Takayasu's arteriopathy. This is also called aortic arch syndrome. It is a rare systemic inflammatory large vessel vasculitis. So there will be autoimmune inflammatory reaction of large vessels of unknown etiology that most commonly affects women of childbearing age. It is defined as granulomatous inflammation of the aorta and its major branches. So that is what is called the aortic arch syndrome. It is observed more frequently in patients of Asian or Indian descent. It occurs usually in young Japanese females. If there is arthritis of the aortic arch with absence of pulses in the carotid and subclavian, then it is called as the pulseless disease. Treatment: controlling the inflammatory process and controlling the hypertension. So the inflammatory process is controlled by corticosteroid drugs or cytotoxic agents are used for patients whose disease is steroid resistant or relapsing. Next is the Burgess disease. So option has some doubt. So first of all, I will clear it. Stenting and grafting, both are limb salvage. Yes, they are both are limb salvage. If gangrene is there, first you can try the interventional procedure. If the interventional procedure is not possible or not feasible, then or the disease is very severe, occlusion is very tight. For example, they do the calcium scoring. So how much calcium is deposited in the plaque? So they will do the scoring. If the calcium score is very high, that means it is a very stiff and hard erythromatous plaque. Even with balloon dilatation, you can't dilate it. That means angioplasty cannot be done. Such cases, you have to go for only bypass operation. So severe cases where angioplasty cannot be done, where angioplasty fail, you have to go for bypass. So both grafting and stenting are called the limb salvage procedures. Now we will go to the Manoj, are able to see the chart now? The Burgess disease. This is also called as thromboangiitis obliterans also called as the TAO. Is one of the most important topic for you. You will be seeing cases of Burgess disease in the clinicals, as well as you will have the questions on Burgess disease in your theory examination, both as an essay question and sometimes as a short notes question. So you must be very thorough with this Burgess disease. Definition: this is a chronic non-specific panvasculitis involving small and medium-sized arteries. Just now we have seen Takayasu's arteriopathy. It is a non-specific vasculitis, but it involves large vessels. This is a non-specific vasculitis involving small and medium-sized arteries and veins. It involves veins also. Takayushi arteriopathy, it involves only the arteries, but here Burgess disease, both arteries and veins are involved. Age before and at the age of 30 years, rare after 40 years. It is practically confined to males, seen in all races. Smoking causes Burgess disease. It is so affirmatively you can say that point means so far Burgess disease is not reported in non-smokers. So you can see the relationship of the smoking and Burgess disease. And one more thing is the treatment for Burgess disease is stoppage of smoking, abstinence from smoking. Only if the smoking is stopped, the disease progression will be stopped. It won't come to normal. It will be stopped, that's all. But if the fellow continues to smoke, the disease progresses. Probably it may be an autoimmune disease. So it involves mainly the lower limbs, occasionally the upper limbs. It starts from the distal vessels. Then it goes to the plantars. Then it spreads to the posterior tibial, anterior tibial, and peroneal vessels. Up to the popliteal artery, it ascends. The disease starts in small vessels of the lower limb, that is distal or plantar arteries, later medium-sized arteries such as the posterior tibial. Other vessels which are rarely affected are the popliteal artery, upper limb, and mesenteric vessels. There is mainly vasculitis of the intima. This leads to thrombosis of the vessels. There is occlusion. The name itself says thromboangiitis obliterans. So that is the pathology. Clinical features: there are features of chronic peripheral occlusive arterial disease. And there is associated features of superficial spreading thrombophlebitis. Peripheral occlusive arterial disease, stage of claudication, chiefly affects the leg and instep of the foot, as the disease affects posterior tibial and plantar vessels. So the pain will be there, in the claudication pain will be there mainly in the leg and the foot. Stage of pregangrene, rest pain and indolent ulcers on the foot and lower half of the leg. Color changes, lack of warmth, retarded hair and nail growth, absence of peripheral pulses, dorsal pedis, posterior tibial, and in some cases popliteal artery. Raynaud's phenomena is seen in males. Then if it is neglected, there will be gangrene of the toes progressing upwards. You can see here, this is a patient with the TAO, where the gangrene has started in the fourth toe. This is a patient with TAO, he came to me with a non-healing ulcer on the left foot. He has already an artificial limb. I asked him why the artificial limb is there. He said that the limb was amputated. What for? He said it is for gangrene. A young fellow, only aged about 35 years. And when I inquired, he smokes at least 20 to 30 cigarettes per day for the past 15 years. So then I asked him, were you not advised to quit the smoking when this amputation was done? He said that yes, they said. Then are you smoking still? He said that yes, he is smoking still. Why? I cannot live without smoking. That was his answer. So even one leg was removed, he didn't realize the value of his limb. So he gave preference to the cigarette, not to his limb. Now he developed a ulcer. That is, what is the stage? What is the stage of vascular insufficiency? What is the stage of vascular insufficiency? Nizami, why do you say it is gangrenous? Is there any dead tissue there? There is only ulcer. It is not gangrenous stage. It is only pre-gangrenous stage. Yes, there is color changes. Their color change is only dark color is there because dark skinned individuals, the erythema is seen as dark color. So investigations same as for chronic occlusive arterial disease. Arteriography is not advised here because direct arterial surgery is not feasible in these cases. Management of claudication. Advised to stop smoking. Patient is asked to choose between cigarette and his limb. And general principles of vascular occlusion management. Already we have discussed. Exercise up to the distance of claudication, diet management, management of diabetes, hyperlipidemia, then platelets modifying drugs. Those things should be used. So you can see here this patient, the same patient. So this is the artificial limb. You can see the other limb. Other limb still there is no ulceration. So first he came to me with this complaint, with the pain in the claudication pain in the left foot. Then I strictly advised him not to have smoking. He continued, then he came to me with the ulceration. So this foot you can see there is fixed discoloration. Aside from experimental use of iloprost, that is prostaglandin analog and thrombolytics, the antibiotics to treat infected ulcers, and palliative treatment of ischemic pain with NSAIDs and narcotics, all other forms of pharmacological treatment have been generally ineffective in treatment of TAO, including steroids, calcium channel blockers, reserpine, pentoxifylline, vasodilators, antiplatelet drugs, and anticoagulants. So all these agents were tried in treating the Buerger's disease. So they were found to be of no use or ineffective. So There is only experimental usage of iloprost or the prostaglandin analog and thrombolytic agents to lyse the thrombus. Still, that is experimental. So now there is no accepted, approved medical treatment for Burgess disease. The only treatment that is available is quitting the smoking. In the pregangrene stage, you can advise the patient lumbar sympathectomy. The lumbar sympathectomy, because it is the sympathetics are the nerves which carry the vasospastic fibers to the vessels. So once you do sympathectomy, there will be spasm will be relieved, and there will be relief of wrist pain with healing of ulcers and improvement in skin nutrition. It is done by open laparoscopic or by injection method. But now also it was proved that sympathectomy is not of help in Burgess disease. So this procedure is outdated and found to be of no use in large studies. Intraarterial infusion of reserpine was also tried, but that also found to be of no use. So there is a lot of work is being going on in the management of the Burgess disease. But none of the treatments at present available are suitable for treating Burgess disease. Direct arterial surgery is not feasible. Like bypass operation, you can't do it because the disease starts in the distalmost vessel and gradually ascends to the proximal vessels. If some block is there, you can do a bypass. But here, such block is not there. It is a diffuse involvement of small vessels and later medium-sized vessels. So you can't do direct arterial surgery. But associated atherosclerotic obstruction of the large vessels can be managed by a bypass graft. So the fellow is having associated atherosclerotic obstruction, then you can manage it by doing bypass graft, which may help for perfusion of the limb. But usually, the Burgess disease patients age group and atherosclerotic patients age group are not one and the same. The Burgess affects less than 40 years, around 30 years. Atherosclerosis affects more than 40 years. So associated atherosclerotic plaque means it is very, 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 very uncommon. So now we are talking about sympathectomy. So I will tell you something about sympathetic system and sympathectomy operation. Anatomy of autonomic nervous system. Of course, this is not so much necessary for you because nowadays the sympathectomy operation is not being advocated for Burgess disease. But why I am telling is, in clinical, sometimes you get cases of Burgess disease, usually as dry gangrene of the toes with severe pain, severe wrist pain. So then the examiner will ask you what are the modes of treatment available. So you have to mention about sympathectomy, and then you must say that now it is out of date. Large studies have shown that sympathectomy has not given any benefit. And sympathectomy is advocated only in the pre-gangrene stage, not in the gangrene stage. So then the examiner will ask you few points about autonomic nervous system. So with that intention, I am telling about this autonomic nervous system to you here. Anatomy of autonomic nervous system: central portion, cortical and hypothalamus; peripheral portion, thoracolumbar outflow, that is for the sympathetic system, that means through the thoracic and upper two lumbar segments, the sympathetic system will come out. Then craniosacral outflow to the 5 or 6 cranial nerves and sacral nerves S2, 3, 4. The parasympathetic system comes out. So this is called the craniosacral outflow or the parasympathetic system. The fibers arise from the visceral or lateral columns of the spinal cord and pass out with the anterior nerve roots. So with the motor nerve root, they come out. The fibers leave the anterior nerve root as white rami communicantis and enter the paravertebral ganglia. So sympathetic nerves, they pass out from the lateral column, they come through the anterior nerve root, and they leave the anterior nerve root as white rami communicantis and they end up in paravertebral ganglia. So the ganglion chain is there, you have seen in the previous diagram. So it comes and ends up here where it synapses. A synapse is there in the ganglion. From the ganglion, the postsynaptic fibers arise. The postsynaptic fibers or postganglionic fibers, they pass out through the peripheral nerves and they terminate in their effector organs or effector cells. So this is the paravertebral ganglionated trunk. The ganglia extend as a chain from the base of the skull to the common iliac vessels. There are 3 cervical, 11 thoracic, and 4 lumbar ganglia. You can see here, there are 3 cervical. They are large. This is superior cervical ganglia, this is middle cervical ganglia, this is the inferior cervical ganglia. And there are 11 thoracic. For 12 segments, there are only 11 ganglia. Then there are 4 lumbar ganglia. For 5 lumbar vertebra, there are only 4 ganglia. The ganglia are connected to all thoracic and upper 2 lumbar roots by preganglionated fibers called white rami communicantis and give off non-medullated gray rami communicantis to all the spinal nerves. So the post-ganglionic fibers are all non-medullated. So these non-medullated fibers, they are supplied to all the spinal nerves. So through the spinal nerves, they pass through the nerves and they reach the skin, the blood vessels, the sweat glands, hair follicles, etc. The ganglia are synapses of the nerves. So this is the ganglionated chain that is there on either side of the vertebra. The sympathetic system has synapses in the paravertebral ganglions, while the parasympathetic have ganglia in the peripheral organs. The parasympathetic system has no ganglionated trunk. They have ganglia in the peripheral organs like Meissner's plexus and Auerbach's plexus. Cervical ganglia supplies sympathetic nerves to the head, neck, and to the upper limbs. So whole of the upper part, that means head, neck, and upper limbs, is supplied by the cervical ganglia only, those 3 ganglia. The inferior cervical ganglia and first thoracic ganglia are usually fused, and this is called as the stellate ganglion. Now and then you get the short notes on the stellate ganglion. The stellate ganglion blockade causes Horner syndrome. I hope all of you know about Horner syndrome. What is Horner syndrome? So it gets Horner syndrome is ptosis, meiosis, and anhydrosis, and also anophthalmos. Anophthalmos. So the stellate ganglion or inferior cervical ganglion, if it is blocked, it's very good. Loss of ciliospinal reflex also is there, very good. And anhydrosis on the hemiface, good. The lower limbs are supplied by lumbar ganglia, and L1 supplies mainly to the thighs and ejaculatory ducts. So, in Burgess disease pregangrene, you can do the lumbar sympathectomy. That means the lumbar ganglia are removed. The cervicodorsal sympathectomy means you have to remove the upper four thoracic and the inferior cervical ganglia. Cervicodorsal sympathectomy, first thoracic to fourth thoracic ganglia are removed. The stellate ganglion, that means fusion of first thoracic and inferior cervical is present. It is removed, or lower part of it below the white ramus from the T1 is removed to save from the Horner syndrome. So sometimes there will be stellate ganglion. If stellate ganglion is there, you have to bisect it. You have to cut it below the T1 nerve fiber so that the cervical Horner syndrome will be prevented. The T1, T2, T3, T4. So these are removed in cervicodorsal sympathectomy. It can be approached through cervical, axillary, dorsal root, but nowadays it is being done by thoracic thoracoscope operation. Then lumbar sympathectomy. Ganglia removed are second to fourth inclusive. The second lumbar ganglion has two white ramic communicantes, and third and fourth have no white ramic communicantes. Already I told you about white ramic communicantes. That means the white ramic communicantes, they leave from the anterior nerve root. They end in the ganglia. They come into the ganglia. So second will have two roots. Third and fourth have no roots. That is how you identify the second thoracic lumbar ganglia. Second lumbar ganglia. So in lumbar sympathectomy, you remove second, third, and fourth ganglia, paravertebral ganglia. It is done by open, laparoscopic, or by injection method. So that is about stage of pregangrene stage. So a patient with Burgess disease, if he is in stage of pregangrene, you can give the general measures, plus you may try sympathectomy operation. That may give some relief, but you must caution the patient that the relief may not be as much as expected. Management of gangrene, amputation through normally perfused part of the limb, that is usually below knee amputation, because the vessels occluded are up to the level of the knee. So you have to remove the limb up to the level of the knee. So a below knee amputation is required. Apart from Takayasu's arthritis and Burgess disease, there are other types of arthritis also are there. They can be due to rheumatoid arthritis, polyarthritis nodosa, systemic lupus erythematosus, diabetes mellitus, temporal arthritis. So these are the organic diseases causing vascular occlusion. The main diseases are atherosclerosis, the Burgess disease, and rare forms of arthritis. Then vasospastic condition. What is the difference between the organic occlusion and spastic occlusion? In organic occlusion, the intima and media of the vessels have been altered. In vasospastic condition, they are normal, but there is spasm of the vessels, which causes occlusion. The most important of these vasospastic conditions is the Raynaud's disease or Raynaud's phenomena. Types idiopathic or primary, secondary. So where a cause is not known for the vasospasm, it is called the primary. Where a cause is there, it is the secondary. Primary Raynaud's phenomena, it is a vasospastic disorder of arterioles due to abnormal response to cold. So the vasospasm occurs only to exposure to cold. That is normal. So if you keep your hand in cold water, your hands becomes your vasoconstriction will be there for your arteries in the hand. But there is an abnormal vasospastic response of the arterioles due to cold exposure. So there will be an abnormal response. So just vasoconstriction is normal, but there will be an abnormal response. What is abnormal response? Let us see. This occurs in young women before 30 years of age and affects the upper limbs. Pathogenesis, there is exposure to cold. It causes exaggerate response of the arterioles. Normally, when you expose your fingers to the cold water, there will be arteriospasm. Once you take away the hand from the cold weather, then there will be vasospasm will be relieved. But here, there is prolonged vasoconstriction of the arterioles and distal arteries. This leads to pallor of the fingers and hand with numbness. This is called phase of local syncope. This prolonged vasoconstriction can lead to anoxia of the tissues there. So whenever anoxia is there, there will be anaerobic metabolism. Anaerobic metabolites, lactic acid, pyruvic acid, and other metabolites, they cause vasodilatation. So because of this vasodilatation, now the capillaries dilate, but the arterioles are still constricted. Capillaries have dilated. So now they fill with deoxygenated blood because oxygenated blood is not being supplied. So there is supply of only deoxygenated blood. This leads to cyanosis. So this is called phase of local asphyxia. So first is the phase of local syncope, next is phase of local asphyxia. Later, after some time, the arterioles relax. So they are not permanently constricted. They are constricted for a prolonged period. So afterwards, they get relaxed. Once they relax, then the oxygenated blood flows into the capillaries. So with this, there will be red engorged hand with burning sensation. This is called phase of recovery. So there is phase of anoxia or syncope, phase of asphyxia, then phase of recovery where the hands become red and engorged. Clinical features: paroxysmal attacks of sequence of blanching, cyanosis, and red painful engorgement when fingers are exposed to cold environment. In severe cases and chronic cases, the fingers become thinned out due to atrophy of subcutaneous fat. So due to repeated attacks, there will be gradual atrophy of the pulp of the fingers and they get thinned out. Only bone will be there, which is covered by the skin. The peripheral pulses are felt normally because the major arteries are not involved here. Only the distal arteries and the arterioles are affected here. In few cases, gangrene of the tips also can develop. That means in severe cases, there will be such prolonged vasoconstriction, which is not getting relieved, can lead to the gangrene of the fingers. So now you can see the dusky congestion. So the hand is cold, this hand is normal, but this hand is put in cold water. Then after first there will be whiteness. You can see the whiteness here and there here. And after 2 or 3 minutes, there will be blueness, and still there afterwards you will see the red hand. This is revascularization. You can see here that means due to first vasospasm, later vasodilatation. So this vasodilatation gives this red hand. You can see this red hand. This is the anoxic finger. Still, the vasodilatation has not taken place in this finger. Investigation: color Doppler scan of the upper limb vessels to see for any vascular disease. X-ray of the thoracic inlet to exclude cervical rib. Even in conditions like cervical rib, there will be this vasospastic problem. Treatment: protection from cold and avoidance of nail bed infections. Calcium channel blockers like difedipine will be of help. Surgery: cervicodorsal sympathectomy was practiced earlier, but not practiced nowadays as the response is not satisfactory. Now sympathectomy is being reserved only for controlling hyperhidrosis of palms and axilla. Some people will have such troublesome hyperhidrosis, so they will be sweating profusely in their palms. So such patients can be managed by this sympathectomy operation. So that is the only indication nowadays. So the earlier indication for the Raynaud's disease has been now not being done for Raynaud's because the results are not so satisfactory, and they are not, even if they are satisfactory in the beginning, they are not lasting. The response is not lasting. Of course, for the sympathectomy operation, endoscopic transthoracic method. I told you the thoracoscopic approach. There is a word primary. That means where no cause is found. Then secondary Raynaud's phenomena. It was also called as Raynaud's disease. It is secondary to other vascular diseases like collagen diseases and degenerative arterial diseases like atherosclerosis, Burgess disease, SLE, scleroderma. So the atherosclerosis mainly affects the subclavian artery of the upper limb. It doesn't affect below that. So the subclavian artery is having atherosclerosis. That patient may have associated Raynaud's phenomena. So collagen diseases of the vessels can cause, or degenerative arterial diseases can cause Burgess syndrome. Raynaud's syndrome. Then second cause is cervical rib. Third, carpal tunnel syndrome. For occupational people working with high frequency vibrating tools like pneumatic road drills, they get this Raynaud's phenomena, and there it is called the vibration white finger. Sometimes it can be there associated with peripheral nerve injuries or paralysis. So here is the cervical rib. So a patient with Raynaud's phenomena. So when we have to investigate by taking the X-ray of the neck to see for the cervical rib. So investigations for diagnosis of collagen diseases: ESR, anti-nuclear factor, rheumatoid factor, immunoglobulins, skin biopsy. For evaluation of vasoocclusion, duplex scan, arteriography in selected cases. Differential diagnosis. So we have differentiated from other conditions where when the fingers are exposed to cold, they get pallor or cyanosis. So what are the other conditions? Acrocyanosis. There is cyanosis of fingers and toes after exposure to cold. This occurs in young females, painless and not paroxysmal, relieved with sympathectomy. It is just similar to that of Raynaud's, but there is only cyanosis here. Other condition is called the chilblains. Painful, multiple localized swellings due to exposure to cold. So whenever a person is exposed to very cold environment, there will be painful, multiple and localized swellings in the extremities. Common in women from childhood and may be familial. The edematous nodules may sometimes ulcerate. Then Bayesian's disease, also called as erythrocyanosis frigida. It occurs in healthy young obese women. In cold weather, the legs develop dusky red patches on skin or skin of the calf muscles. Later, the subcutaneous nodularity, induration, and ulcers develop. Treatment treatment of collagen diseases with steroids, treatments of Raynaud's phenomenon if it is associated, you give amphetamine, avoid using vibration tools. So that is about Raynaud's disease. Then miscellaneous occlusive arterial diseases. Any doubts in the Burgess disease or in the Raynaud's? Because there are two are the important topics. Raynaud's will be given in the theory examination. Burgess disease can be given in theory as well as in the clinicals. Okay, if you have no doubts, we'll proceed to the miscellaneous occlusive arterial diseases. Compartment syndrome. We learned about abdominal compartment syndrome. Similarly, peripheral compartment syndrome. So this is the leg where there are two bones, tibia and fibula, separate. They are connected by interosseous membrane, a tough membrane. And there is a deep fascia of the leg which encloses all the muscles. This is the anterior compartment, and here is the lateral compartment, and this is the posterior compartment. So each compartment has neurovascular structures passing through it. And each compartment, if you see, this is bounded by bone on either side and interosseous membrane on posteriorly and deep fascia of the leg anteriorly. So it is a very tight compartment. And this is also a tight compartment. And this is also a tight compartment. So if edema of the muscles occurs due to any reason in these compartments, they cannot swell. They are tightly put into this compartment. So there will be a compartment syndrome where they cause pressure within themselves. This pressure can cause destruction of the muscles, leading to liberation of myoglobin into the circulation. And they can cause pressure over the nerves and cause the anesthesia and paralysis. Pathogenesis: post-traumatic hematoma or edema in the osteofacial compartment of the leg or forearm. Usually following fracture or tight POP application, leads to distal ischemia because of vascular occlusion. And crush syndrome, that means the muscles are put to crushing, that will lead to liberation of myoglobin and myoglobinuria and the renal failure. If ischemia of the or if the compression of the blood vessels that are there in the compartment is not complete, if there is a partial obstruction, that can lead to a condition called the Volkmann's ischemic contracture. So the lateral or anterior compartment of the leg or forearm compartments becomes tense and tender after trauma with absent peripheral pulses, and later the nerve function also is absent. Gangrene occurs if vascular occlusion is complete. Volkmann's contracture occurs if the vascular occlusion is partial and progressive. So what you should remember in compartment syndrome is anything which causes edema of the leg muscles, can lead to swelling of the muscles with compression in the compartment, leading to crush syndrome, vascular occlusion, nerve compression. The vascular occlusion manifests with absence of distal pulses. If it is partial, it will lead to the Volkmann's ischemic contracture. In progressive ischemia, there will be ischemia of the microcirculation of the muscles and nerves, leading to fibrosis and contracture of the muscles with paresis of the nerves. So the muscles, they undergo necrosis and they are replaced by fibrosis. And there will be associated paresis of the nerves also. Clinical features: earliest symptom is pain, which is disproportionately higher than the trauma and which increases and passive stretching of the affected muscles. For example, if this compartment is showing compartment syndrome, why? For example, there is some fracture of the radius or ulna, or there is some contusion hematoma. So this can cause the edema. The tight edema can make the compartment very tight. So when you feel, you will feel tenseness. The normal flexibility is absent. And the muscles become stiff. When the muscles are stiff, what will happen? Automatically the fingers undergo flexion attitude. If you try to hold the fingers and try to extend them passively, that causes severe excruciating pain. So passive extension of fingers or toes causes extensive pain. So once you are posted as a house surgeon in the orthopedic department, after POP application, if some patients will come to you with fractures, so then you do closure reduction and then apply POP casing. So once you apply POP casing, the forearm is not seen. So you do not know whether the muscles have become tense or not. Then how to know whether the POP is tight? How to know is by passive extension of the fingers. After application of the POP, what you must do is you must hold the fingers and you must try to extend them. If they can be extended freely, then there is no problem. If there is pain on extension, means the plaster is tight or the underlying compartment is tight. So you have to remove the plaster and reapply, check whether the compartment syndrome or not. If there is no compartment syndrome, then you must apply plaster in such a way that it is not going to cause tightness. First symptom is only this one. Stretching of the fingers makes lot of pain. Next, there will be lack of sensation and followed by paralysis of the affected muscles. The peripheral pulses may not be palpable. In established case of neglect occlusion, there is permanent contraction of the muscles. So because of the pain, the patient keeps the fingers in this attitude only. So the muscles get fibrous. When the muscles get fibrous, means the muscles also will be contracting in this state. So patients will have the attitude of the flexion attitude of the fingers. In upper limb, flexors of the forearm are affected commonly, resulting in flexion of the wrist, extension of MP joints, and flexion of the IP joints. The fingers can be extended on complete flexion of the wrist. Treatment: removal of the tight POP casing, fasciotomy of the affected compartment. If any vascular occlusion is present, it must be treated. In established cases, muscle transfer or tendon lengthening are done. Okay, Santi, you have a doubt. How can we decide if plaster of Paris is rightly applied. Yes, extend the fingers after applying the plaster of Paris. Look for the pulps for vascularity. You just press the pulp and leave it. There will be blanching, and return of blanching to normal color will be there immediately. If there is delayed return of the normal pink color, that means that there is vascular occlusion. So you can test either in the pulp or in the nail bed. You press the nail bed, it becomes pale, leave it, it becomes pink. But if there is vascular occlusion, it will not come like that. So main thing is you have to look for the stretching of the fingers and pain. Then the nail bed response. If possible, you can feel the pulsation. Because POP will applied up to the wrist. That is why the pulsations will not be able to be palpated. You must check only with these signs. Or if you have a Doppler's probe, you can check the Doppler's, keep the Doppler's probe over the distal arteries and you can see the pulsations. Then next condition is the Einham, etiology not known, incidence black males, pathology. A fissure appears at the level of the interphalangeal joint of a toe, usually the fifth toe. So for unknown reason, there will be a groove occurring at the base of the fifth toe and it gradually deepens. It becomes a fibrous band. So this fibrous band constricts the toe and makes it avascular and causes gangrene. Treatment is you can cut the fibrous band and reconstruct by doing Z-plasty operation. Amputation if gangrene develops. The next condition is the thoracic outflow compression syndrome, also called as the thoracic inlet syndrome. What is the thoracic outflow compression syndrome? Compression of vessels and nerves that outflow from the thoracic inlet. This is the thoracic inlet. Posteriorly, it is T1 vertebra body, and either sides the cervical ribs. On either side the first thoracic rib. In front is the manubrium sterni. So this is the thoracic inlet. Through this inlet, some structures they go out. So compression of the vessels and nerves that flow out from the thoracic inlet is called the thoracic outflow compression syndrome. This is one of the causes of extraneous compression of the arteries. So you can see the first rib here. This is the clavicle and the subclavian artery, the lower trunk of the brachial plexus, they are passing out through this tunnel. So this is the thoracic inlet. At the exit from the neck, the brachial plexus subclavian artery passes through a narrow triangle bounded by first thoracic rib, scalenus anterior muscle anteriorly, scalenus medius muscle posteriorly. So in this triangle, these neurovascular structures they pass out. But subclavian vein, it travels in front of the scalenus anterior muscle. If these structures are compressed, it is called as thoracic outflow syndrome. Causes. Why these structures can be compressed there? It can be due to a presence of cervical rib or due to scalenus anterior muscle itself. Cervical rib. The base of this triangle is raised by a height of one vertebra level, causing angulation of these structures. So this is the first rib. Here is the cervical rib. If a full formed cervical rib is there, then the subclavian artery, instead of going like this, it has to go like this. It has to ascend. Similarly, the D1 and C8 nerve roots, they also has to ascend over this cervical rib. So they are put to stretch and angulation, causing obstruction. If cervical rib is not there, then scalenus anticus muscle may be responsible. These structures get compressed or angulated when they pass through the wedge between the tight scalene anterior muscle and cervical rib or first rib. For example, the first rib is there. The first rib is not horizontal. It is sloped downwards anteriorly. So it is anteriorly, it is sloped downwards. So the vessels running on this try to come down like this. But scalenus anticus muscle holds them. So in this angle between the between the first rib and scalenus anticus muscle, these vessels and nerves can be compressed sometimes. So this is called the scalenus anticus muscle syndrome. Vascular changes. If the vessel is put to constriction from extraneous source like cervical rib, or it is compressed between the scalenus anticus and first thoracic rib, what will happen? The arterial lumen is constricted at the point of the crossing of the rib. This leads to, so whenever the vessel is constricted, for example, I think you have, now and then you will be gardening your household plants. When you partially occlude the tube or the hose, the water will come with a jet with more force. So when you want to eject it to a greater distance, you just partially close the tube so that the water will be forced against. So similarly, when there is partial obstruction, there will be more force immediately after the obstruction of the blood. So because of this jet-like force, there will be post-stenotic dilatation. Thrombus forms in the lumen of the post-stenotic dilatation. This thrombus can cause chronic vascular occlusion. So the angulated vessel is not going to cause the obstruction. What is going to cause obstruction is the post-stenotic dilatation, thrombosis, occlusion. Sometimes emboli may dislodge from this thrombus, and that embolus can cause obstruction distally. So that may produce acute vascular occlusion. Neurological changes. The first thoracic nerve is angulated and produces neurological symptoms. The types of cervical rib, it may be a complete rib articulating with the sternum or the first rib. It may not articulate but may end with the bulbous end. This partial rib with a fibrous band anteriorly. Sometimes the whole rib is not formed ossified, it is only as a fibrous band will be there. It presents as local symptoms, vascular symptoms, and neurological symptoms. Local symptoms, you can see a hard lump is there. You may mistake it for a secondary deposit in the cervical nodes. This hard deposit is nothing but the bulbous end of a cervical rib. Vascular symptoms are present in the type A rib, where a complete rib is there, then the patient will have vascular symptoms, claudication pain in the forearm, Pregangrene stage produces color changes, rest pain, and lack of warmth. Bruise over the artery in the neck. Then trophic changes in the fingers with ulceration, rarely gangrene. Signs: pulsatile swelling in the root of the neck due to post-stenotic dilatation of the subclavian artery. Peripheral pulses, radial, brachial, may be feeble or absent. Adson's test. You feel the radial pulse of a patient in a sitting posture. Then ask the patient to turn the head upwards and sidewards. Sideward means to the side of the lesion. So to the side where you are examining, to that side, the patient has to turn his chin and look upwards. Then he should take deep breath and hold it tight. Then the pulses will disappear. If cervical DB is present, the radial pulse will disappear. So if he holds breath like this, the thoracic case expands and the upper lips are lifted up. So because of lifting up, so there will be more angulation. And when the patient keeps the head in this posture, there will be tightening of the scalenus anticus muscle. So there is tightness of the scalenus anticus muscle, plus the thoracic inlet is being elevated up in this posture. So there will be more angulation of the blood vessel causing the obstruction. So the obstruction becomes aggravated, causing the absence of radial pulse. This is called Adson's test. Then neurological symptoms. They are rare, present usually in type D, that means where cervical DB is represented by only a fibrous band. There will be paresthesia of the medial side of the forearm and hand because the T1 dermatome is affected. So there will be paresthesia of the medial side of the forearm and hand. Sometimes there may be wasting of the small muscles of the hand. The small muscles of the hand are supplied by T1 and C8. Both of them supply the small muscles of the hand. So there can be wasting. What are the small muscles of the hand? What are the small muscles of the hand? Yes, lumbricals and intraosteal are called the small muscles of the hand. The thenar and hypothenar muscles, they are not called the small muscles. Then there may be stimulation of the sympathetic nerves that are coming in the T1 segment. So that can be, they are stimulated and they can cause the vasoconstriction producing Raynaud's phenomena. Differential diagnosis of vascular features. You have to differentiate them: Raynaud's disease, atherosclerosis of the subclavian artery, because the patient's complaint will be intermittent claudication of the hand and there may be rest pain with color changes. So they can be there in any of the vascular occlusion. The vascular occlusion can be due to Raynaud's, atherosclerosis, Burgess disease, rarely. This is rare, Burgess disease is rare, or collagen disease of the vessels. That is arteritis. Then differential diagnosis of neurological features: wasting of small muscles of hand. So this can be due to syringomyelia, spinal tumors, poliomyelitis, progressive muscular atrophy, cervical spondylolisthesis. Then brachial plexus causes like Pancoast syndrome, prolapsed intervertebral disc, cervical spondylosis. They cause only paresthesia. The nerve lesions like direct trauma or indirect trauma by bone fragments in a fracture, leprosy, peripheral neuritis, carpal tunnel syndrome. Then muscle lesions like muscular dystrophy. So you have to differentiate if there is lumbricals and intraosteal paralysis from these conditions. Investigations: X-ray of the thoracic inlet, Doppler scan, arteriography. So you can see a cervical rib, on plane X-ray of the chest. Treatment: conservative, correction of postural defects. Usually, these symptoms will come as the patient grows little older. So when the person becomes little older, what will happen is the shoulders they drag downwards, making the angle between the neck and the shoulders more obtuse. So when they become more obtuse, then the vessel and nerve are put to more stretch. So what you must do is you must correct the postural defects by shoulder exercises so that the shoulders can be lifted like this. Not so much extent. They are not drooped down. The brace the tone of the trapezius and levator scapulae to avoid prolonged hyperadduction, especially during sleep. Some people they keep the hand like this during sleep. So this hyperadduction also can cause the neurological problems. Surgery indications: persistent pain, motor palsy, features of vascular insufficiency. Procedure: extraperiosteal excision of the cervical rib plus craniotomy plus sympathetic denervation by cervical or by axillary approach. So that is about the extraneous causes of occlusion of the blood vessels. So the delayed obstruction of the blood vessels will lead to gangrene. Apart from the vascular causes, there are few other causes for gangrene. That is why now let us study about the topic of gangrene here. So before we go to the topic of gangrene, I will just ask a simple question. Define gangrene. What is the definition of gangrene? It is a basic definition, isn't it? Everyone should by heart these definitions. Okay, gangrene is death of tissue en masse with putrefaction superadded. It need not be always due to loss of blood supply or ischemia. Death of tissue due to any cause with putrefaction is called gangrene. Cardiac muscle, if it dies, what do you call it? Cardiac muscle dies, then what do you call it? What do you call coronary infarction? Coronary, sorry, I told you the word. It is infarction, myocardial infarction. But if limb becomes avascular and dies, we call this as gangrene. Both are death of tissue only. Why one is called gangrene and other is called infarction? Because the tissues which die, if they are exposed to the environment, they are acted upon by putrefying bacteria. These bacteria cause the putrefaction. Then we call it as gangrene. If the structures are dead but not exposed to the external environment, they are not putrefied, they simply die. Then we call it as infarction. So we call it as cerebral infarction, myocardial infarction. Bowels, what do you call them? If there is death of bowels, what do you call them? Is it infarction or gangrene? Bowels. Gangrene. Why? Because they get putrefied, because there are commensals in the gut. So they cause putrefaction. So it is gangrene. Okay. Now let us study about the gangrene. Death of macroscopic portion of tissue with superadded putrefaction. Necrosis means death of microscopic portion of tissue, that is cells. So it is a microscopic word, necrosis. Gangrene is a macroscopic death of tissue. What are the causes? Vascular occlusion. Already we have studied about the vascular occlusion. They are classified into acute and chronic. Acute is trauma, thrombosis, embolism, intraarterial injection of certain drugs. Then chronic occlusion, atherosclerosis, Burgess disease, Raynaud's phenomenon, ergotism, diabetes mellitus, and sometimes obstruction to the large veins like femoral vein and iliac vein can cause gangrene. So number one cause is vascular occlusion. The other causes for producing gangrene is infective causes. Example, carbuncle. What is carbuncle? Define carbuncle. I told you so far 2 times the definition of carbuncle. Okay, it is spreading infective gangrene of skin, subcutaneous tissues, and the kidney. Then other infective cause is gas gangrene, Fornis gangrene. What is Fornis gangrene? What is Fornis gangrene? It occurs in the scrotum. It is idiopathic gangrene of the scrotal skin. Next cause is trauma, direct trauma and indirect trauma. Direct trauma is pressure source, constriction by hernial rings on bowel loops. Indirect trauma, pressure of a fractured bone fragment on vessels causing vascular occlusion. Due to constant pressure on the skin and subcutaneous tissues, due to lack of change of posture. So the fellow will develop the death of tissue there. That's called the bed sore. Then physical causes like burns, frostbite, chemicals, irradiation, and electricity. These things can cause death of tissue and later putrefaction. So this is carbolic acid induced gangrene. The gangrene due to electricity. So gangrene causes being not only due to vascular occlusion, they can also be due to other causes like infections, trauma, physical agents. Then it's divided into two types, dry gangrene and wet gangrene. Dry gangrene, it occurs due to slow arterial occlusion. The part is dry and sterile. The moist gangrene occurs due to sudden arterial occlusion or due to arterial and venous occlusion or due to superadded infection. The affected area is moist, swollen with blebs. I told you when large veins are being occluded that can produce gangrene. It is due to massive thrombophlebitis of iliofemoral vein. Iliac vein and femoral vein, if both of them are thrombosed, then it can cause. There will be sudden severe cramp-like pain in the calf. The foot and leg is swollen and tense and deeply cyanotic, associated with profound shock due to trapping of large amount of blood in the lower extremity. After 45 minutes, the limb appears gangrenous and later gangrene gets confined only to the toes. Peripheral pulses are absent due to sympathetic spasm. Doppler is helpful in diagnosis. Clinical features of gangrene, there is death of tissue. Death of tissue means there is no function for the tissues. So what is the normal function of the tissue? Mobility, sensation, warmth, pulsation, and venous return. So these will be absent in the affected area. Color changes, initially paler because of lack of blood with lack of response to pressure, and later gray, motile, purple, and finally brown due to disintegration of hemoglobin and formation of iron sulfide due to putrefaction. So due to putrefaction, hydrogen sulfide is released. That hydrogen sulfide combines with the iron in the hemoglobin and forms the iron sulfide. Clinical features of gangrene, line of demarcation. Now when you closely look at this gangrene here, this is the gangrenous area, and this part is a granulating zone separating the normal viable tissue from gangrenous area. This is called the line of demarcation. You can see here the line of demarcation. Similarly here, the zone separating the viable tissue from the dead tissue due to development of granulation tissue. It is well marked in dry gangrene. It is not well marked in spreading gangrene, and it is at a higher level in moist gangrene. Investigation to identify the causes, especially for vascular occlusive disease. Because the commonest cause of gangrene is because of vascular occlusion, you have to do the duplex scanning and Doppler study. Treatment, general measures, treatment of hypertension, diabetes, mellitus, anemia, cardiac failure, and malnutrition. Treatment of the cause, vascular diseases by direct arterial surgery or by indirect arterial surgery like sympathectomy. Infection controlled by appropriate antibiotics and surgery. Amputation, but gangrenous area is dead area. The dead area has to be removed. What is the level of amputation? Again, the level of amputation is dependent upon the perfusion of the proximal tissues. In atherosclerosis, the major vessels are affected, like the femorals and iliac vessels are affected. So the tissues proximal to the gangrene are also ischemic, though not gangrenous. So there is lack of perfusion up to the level of knee in case of femoral artery atherosclerosis. So the proximal tissues can be salvaged by arterial reconstruction, and amputation of the affected part only is performed. So already we studied about this point in the atherosclerosis topic. Then is salvage limb surgery. In Burgess disease, the disease affects distal, plantar, posterior tibial, and sometimes popliteal artery. Hence, the patient usually requires a below-knee amputation. So that is the general features of the gangrene. Now let us go to the specific diseases causing gangrene and study about them. The diabetic foot. It is also given now and then as a short notes question in the theory examination. Manifestations of foot in diabetes mellitus. Deformed foot due to neuropathy. Diabetes mellitus causes not only the hyperglycemia. Because of the persistent hyperglycemia, patient get neurovascular manifestations. What is neurological manifestation? There will be neuropathy. The transmission of the signals in the peripheral nerves gets decreased, probably associated with demyelination. Vascular changes, there will be arteriolar thickening. There will be arterioles, generalized arterial thickening will be there. And diabetes enhance the atherosclerotic process. So there will be vascular changes as well as neurological changes. So both these changes contribute to the diabetic foot formation. So the manifestations in diabetic foot being number one, deformed foot due to neuropathy, then chronic ulcers, gangrene. So these are the three manifestations. Deformed foot. Why there is deformed foot? Due to neuropathy. Because of peripheral neuropathy, there will be sensory disturbances producing the lack of sensation in the foot, and there will be motor neuropathy with paralysis of certain muscles of the foot. So this can lead to the deformity like hallux, hammer toe, limited joint mobility. So you can see here this patient is having the hallux valgus. Do you know? I hope you know about valgus and varus deformities. What is valgus deformity? What do you understand by valgus deformity? No, it is no, it is incorrect. What's meant by hallux? Bent towards midline, that is varus deformity. Bent away from midline is called valgus deformity. Hallux means great toe. Pollex means thumb. So hallux valgus means great toe bent away from the midline. You can see here. Here the great toe is being deviated to the lateral side. So with this deviation, what is happening? There is no space for the second toe. That's why the second toe has been lifted up over the first toe. So this is called the hammer toe. You can see this deformity. This is just like a hammer. Then there is limited joint mobility because of neuropathy. And this also causes, here you can see, the first metatarsal head is so prominently projecting outwards. So they can cause a pressure sore here. A pressure ulceration can form here. Yes, knock knees means the knees are like this. They are called the genu valgus. If the knees are like this, if they are like this, they are valgus. If they are like this, varus, genu varus. Yes, towards the midline means it is varus. Towards midline means varus. That means there should be adduction. If there is abduction, we call it as valgus. If there is adduction, we call it as varus. Yes, adduction is varus. No, it is not valgus, it is varus. V-A-R-U-S. Abduction is valgus. Anyway, you can refer your orthopedics book tomorrow and tell me, confirm it. Then there may be abnormal pressure loading, particularly on the metatarsal heads and heel. You can see the metatarsal head, there will be abnormal pressure loading. And there will be callus ulceration or chronic ulceration. So the second feature in diabetic foot is the formation of ulcers. Usually trivial trauma results in foot ulcers and they become chronic and spread with associated necrosis of the tissues in a diabetic patient due to the following. Due to ischemia, there is microangiopathy. Already I told you there will be thickening of the arterial media. So that causes the arteriolar constriction. There will be associated atherosclerosis. Then due to trophic changes, peripheral neuropathy. Peripheral neuropathy causes lack of sensation. So lack of sensation causes trophic ulceration. And due to infection, the infection is because of excessive glucose in the tissues, which predisposes to infection. So these three factors causes the ulceration: ischemia, neuropathy, and infection predisposition due to hyperglycemia. Then there can be development of, third feature is the development of gangrene due to ischemia and infection. So somatic neuropathy causes anesthesia and abnormal pressure load due to deformity. This causes a callus. Callus means thickening of the skin. There will be scaling and thickening of the skin. This can lead to an ulceration. Then there is autonomic and motor neuropathy. This leads to warm, dry skin with clawfoot. What is clawfoot? This occurs in posterior tibial neuropathy. When the posterior tibial nerve is involved, then patient develops clawfoot, and this leads to callus formation. This leads to ulceration. Peripheral vascular disease causes ischemia of the tissues that can cause gangrene or ulceration. Treatment: control of diabetes mellitus, control of vascular insufficiency. Vascular insufficiency can be controlled with pentoxifylline tartrate, platelet modifying drugs like aspirin and clopidogrel. Then vascular assessment with Doppler probe, ankle brachial pressure index, color Doppler scan for vascular obstruction by atherosclerosis. If atherosclerosis of femoral or popliteal is present, bypass surgery is contemplated to revascularize the limb. Control of infection, rest, sometimes in a PVOP case, antibiotics, drainage of collections and pus, excision of sloughs, callus, and sequestrum. Then production of pressure areas by foam or PVC cushioning. Management of gangrene. If peripheral pulses are present, conservative amputation is needed. If peripheral pulses are absent, vascular investigations are done and bypass operation done on the vessel to salvage the limb by a conservative amputation. If such is not feasible, the gangrene spreads proximally and a major amputation will be needed. So diabetic gangrene, usually you have to do amputation depending upon the peripheral vessel assessment. If the peripheral vessels are normal, that means there is no atherosclerosis. The gangrene is because of arterial thickening, microangiopathy. So you do amputation of the local parts. If there is associated atherosclerosis is there, as evidenced by duplex scanning, you have to do the reperfusion technique or limb salvage operation. Otherwise, the gangrene will spread upwards and patient goes for a major amputation. Bed source. Again, this is another short notes question. Is also called decubitus ulcer. Causes. So what is bed sore? When the patient is lying in the bed for a prolonged period without changing the posture. When you are sleeping, you won't be in the same posture. Your body will be moving this side and that side and that side and this side. But by any chance, if a patient stays like that in the bed in only one position, then the pressure points where they are in close contact with the bed, so those areas, they undergo pressure necrosis and gangrene. So one of these such sites, the sites being the back of the sacrum. The patient lies on his lateral side, then he will develop pressure sores on the greater trochanter. The patient lies on his front side, he will develop the sores over the iliac crust. That is why patient should not be in one single posture. It should be moved frequently. So in patients with paraplegia, the patient cannot move. He must be nursed to be moved. Or malnutrition. So when the patient is very weak, malnourished, lying in the bed, so he will not be able to have the energy to move also. There is malnourishment of the skin, subcutaneous tissues, so there is lack of nutrition, so that produces predisposition to gangrene. Sites of occurrence, areas with little fat or muscle. So little fat or little muscle or bony prominences like back of the sacrum, greater trochanters of the femur and iliac crust. The factors responsible for bed sores being pressure, friction, moisture, anemia, malnutrition. So these factors help formation of the pressure sores. Clinical features initially as erythematous patch which does not blanch. So we have seen in the pregangrene stage, there is fixed discoloration. How do you differentiate between fixed discoloration and erythema of inflammation? I told you by blanching test. So on pressure, it doesn't blanch, means it is fixed discoloration. Fixed discoloration indicates that there's capillary ischemia with extravasation of blood into the tissues from the capillaries. So that causes the redness. Later, deep penetrating ulcers develop on the bony prominences. So this patch, erythematous patch becomes brown, and that brown becomes a scab. The scab gets denuded and that leaves behind an ulcer. And that gradually gets deepened till the bone is being exposed. Treatment, prophylaxis is the most important thing. So you must identify the susceptible persons and you must prevent bed sores in them. Already I told you malnourished individuals and paraplegic persons, they are susceptible for bed sore formation. And sometimes old people will be there, very old people who are bedridden. So daily activities also, natural activities also will be there in the bed itself. They have urinary catheter, they will have the sanitary mops for cleaning the fecal discharge. So those people, they will be there on the bed only. They won't walk, they won't sit. They are also prone for this bed sore formation. All bedridden patients with malnutrition, paraplegia, prolonged coma, and patients on mechanical ventilator. So you should do prophylaxis. What is prophylaxis? Skill in nursing. 2-hourly change of posture. Production of bony prominences by foam PVC blocks, sheepskin, alpha bed, ripple bed, etc. That means you must protect the bony prominence areas with these appliances. Avoidance of moisture of the skin due to excess sweat, urine, or pus-soaked bedclothes. You must change them frequently. Dusting of the skin and silicone spray, proper urinary drainage, avoidance of friction and pressure by wrinkled bed sheets, by proper bed making. Even the wrinkles on the bed sheet can also cause pressure over the skin and can predispose to these bed sores. Opsite, that is a polyethylene film that can be applied over the incipient bed sore. Incipient bed sore means where there is fixed discoloration. This is the alpha bed. So you can see here, they are like hexagonal cells will be there in the bed. That is connected by a pipe. And these cells, they have spaces. They are filled with air. So there is a motor will be there. The motor inflates some cells at one particular time and some other cells at some other time. You can program it. For 5 minutes, alternate things will be swollen with air. Then they get deflated, then other cells will swell. So there will be alternating pressure. So this is bed sore mattress, air pump. Treatment, it is very difficult to heal a bed sore. Conservative measures. Avoidance of pressure, correction of anemia and malnutrition, surgery, excision of slough and local rotation flap skin grafting. So in the rotation flap, what you see is you get a piece of muscle also. You get the muscle, for example, gluteus maximus muscle can be rotated and placed between the sacrum and the skin. That acts as a cushion. So this is called rotation gluteal skin flap. There are a few more conditions of gangrene. Shall I continue or stop? Because today is festival. Shall I stop it here? Okay, I will stop it here, and we'll continue on this this arterial diseases. Still, there are about 45 minutes talk is there, so I will continue it in the next class that will be on Monday. But in the schedule, it is already completed. That's why what I do is I will send you link to your email ID. So you need not go to the website. You will directly get a link to your email ID. So you can click the link and you can access the class. I hope you got it. So please check your emails on Monday morning. So you will have a link. So you press the link or you click the link, you will be connected to the Zoho website as to my class. So we will complete the topic on this arterial diseases. Later we will have case discussion on disease of the breast, because you asked me to have the case discussion. So tomorrow you be thorough with the disease of the breast. We will have a good lively discussion on Monday. Then after Monday, what classes do you want? See, please go through the book and see if any topics are difficult for you to follow. You tell me, because most of the general topics can be followed easily by going through the book. They need no explanation. But if you find difficulty with any of the topics, you please tell me. We will go with those topics later. Okay? So you please tell me on Monday what topics you want. You please list out and tell me. If you have any topics, we will continue. Otherwise, if you don't require any of the topics where you can go through the book easily, then I will stop this course. Okay, thank you very much. See you on Monday again. Santi, do you have my book with you? Okay. Okay, you do one thing. You please tell me, those who want my book, please write to my email. That is yogiramb@gmail.com. yogiramb@gmail.com. So I will mail my book to you. So for so long you are with me, so I am giving the gift to you. So those who want, you can mail it to this email ID. So you can just mail your address where you want to have the book. I will do the book post to your address. Okay. You can go through my book. Much of the topics what I am telling you here, I will be there in the book, so you can easily follow that. Okay. Thank you. See you on Monday again. Good night.